I'd like to welcome everybody here to a presentation of our CF Discovery Series produced through CFRI Live. The CF Discovery Series was developed in collaboration with Camille Wasowich, who's a nurse practitioner at Stanford CF Adult Clinic, and designed to make CF information accessible to the CF community. Before I begin, I'd like to note that no information presented tonight is intended for a patient's diagnosis or treatment. So as always, we urge you to work together with your health team. Tonight we look forward to our presentation on understanding CF, organisms, and antibiotic therapies. Thanks to Genentech and to AMED Healthcare for supporting this important evening. Their support pays for the venue and refreshments, the studio we have constructed here at the Crown Plaza in Palo Alto, and other costs associated with the program. Tonight's program is being filmed by staff member David Suhu, and volunteer Eric Martin is handling the streaming portion of this production. Many thanks also to Scott Wakefield for all of his guidance. So here we are live at the Crown Court Cabana. I encourage you all to ask questions, whether you are here in the audience or part of our online community. And a special shout out to anyone of those of you out there who are in the hospital. We look forward to your questions, especially for how we can help aim for better quality of life. And finally, thanks to our volunteers for serving food and helping us with our cross-infection guidelines. We have two speakers tonight. We have Ellen Jo Barron. Dr. Barron is an Associated Director of Clinical Biology at Stanford Medical Center, and I will do an even better job with that introduction in a second. I need to amend that already, I can see. And Deepak Suskadaya, I'm counting on you, sir, to help us, who is a pharmacist also from Stanford Medical Center. To begin our program, Dr. Barron is Professor Emerita at the Stanford School of Medicine, the Department of Pathology. She is the Director of Clinical Virology and Microbiology Labs. She has lectured on microbiology issues all over the world. She is the author and editor of the major reference book on diagnostic microbiology, a project she has worked with for the past 12 years. I have had just this short time to meet our speaker, and she is all over the world. She's doing so many things for the health and diagnosis of patients, not just with those elements affecting cystic fibrosis, but so much more. So, with that slightly stumbling introduction, I do welcome Dr. Ellen Jo Barron. Please give her a hand.
Thank you, Carol, and thanks to Camille for inviting me. And I'm very happy to be here, and you'll all be happy that I broke my foot, which means I won't talk as long as I usually do because I probably can't stand that long on one foot. I'm trying to get the slideshow to run. All the way to the left? From beginning. Thank you. So I was asked to discuss the microbiology laboratory's approach to cultures from patients with cystic fibrosis. So I thought I would start at the beginning and take you all the way through to the end, and then Dr. Sisodia will follow me and tell you how the patient and the antibiotic susceptibility pattern that our laboratory produced are put together for treatment purposes. So first of all, I want you to know that we had to create special orders for our cystic fibrosis patients to remind physicians when they order sample culture work from patients with cystic fibrosis to order the special cystic fibrosis culture setup. And this is a problem that goes on year after year because we get new physicians, changing nurses, and they forget to order cystic fibrosis respiratory. They may just order sputum culture, but that's not the same thing, as you will see. So we add special media for Staphylococcus aureus and Burkholderia cepacia, and that is not added to a standard sputum culture or respiratory culture, sinus culture, whatever other sort of respiratory sample we receive in the laboratory. And we also have special treatment for the cystic fibrosis mycobacteria or acid-fast bacteria cultures and more stringent decontamination. And if we don't know in advance that these are cystic fibrosis samples, they will not receive that special treatment in the laboratory. Sometimes the laboratory technologist, on looking at the plates, can recognize the kinds of organisms that are typical of cystic patients, and then we get a call as a director and go back and call the caregiver and say, you didn't order the right kind of sample testing, please remember in future, etc. But I just want you to know that. So if you are a patient care advocate or a patient, be sure to check that when the sample is ordered for culture in the laboratory that they say cystic fibrosis on it. So what happens? The sample is collected, sometimes in an outpatient setting, sometimes at the hospital, and it is delivered by a courier to the laboratory, which is on Hillview Boulevard, 4 miles away from Stanford Hospital. So couriers bring samples to the back door many times during the day, and once they come in the back door, they are accessioned in the general accessioning area of the Hillview Laboratory facility. From there, they are delivered to microbiology, where they are again logged in to a computer system, and at this point in the microbiology laboratory, labels are printed that include a label for all the different kinds of plates and media that we set up for that sample. Once the labels are printed, these are the kinds of media that we use for cystic fibrosis patients. You probably didn't realize that these many plates were set up. If a culture for routine bacteriology is asked for, we do 5% sheep blood agar, which grows most things. We do something called colistin nalidixic acid, which is a selective agar that kills the gram-negative organisms and allows gram-positive organisms like streptococci and staphylococci to grow. McConkey agar normally grows gram-negative organisms and helps us to differentiate those. I'll show you examples in a moment. Chocolate agar. It looks like chocolate. Don't eat it. Tastes horrible. And it grows Haemophilus species, but it also grows every other kind of organism that is available in these samples. Then we have the special agars, a chromogenic agar for Staphylococcus aureus, and a Burkholderia cepacia selective agar. If fungus cultures have been ordered, we'll set up 3 more plates, Chrome agar candida for yeast, and 2 different media, Stanford potato agar and micocell for molds. And then we make slides. We put the sample on slides and we stain them depending on what kind of sample what kind of culture request the physician has ordered. So this is what goes on at the very beginning, and I haven't even talked to you about the acid-fast culture for mycobacteria, which I'll hit in a moment. So the sample is inoculated onto culture plates. In the upper left-hand side, you see one of our laboratory assistants taking the label off the label printed material and placing it onto the agar plates, and then she uses a swab to place an amount of the sputum or the sample, whatever it is, onto all those different agars that I just told you about. And then they go into the incubator. In the upper left, you see all those plates incubating in the incubator, and each day those plates are brought out of the incubator to the respiratory bench, where a certified clinical laboratory scientist who is licensed by the state of California examines those plates and begins to work on the organisms that are growing on those plates in the laboratory. So the main thing you need to understand about this whole process is that the cystic fibrosis organisms are caught up in a matrix produced by the patient and sometimes produced by the organism, and so they're not growing as fast as normal organisms do, and so this process goes on for a long time, many days, much longer than normally happens with patients that are not suffering from cystic fibrosis. So on day 1, after overnight incubation, and you know what, I'm going to grab a pointer, which I happen to have.
It's one on top of his podium.
Oh, is it there? Oh, great, thank you. Okay. Green one, I really like the green ones. All right, so this is the chocolate agar plate, and you can see some colonies. Can you see them little dots on there? That one is the one that grows most things, and this blood agar plate also grows a lot of things. That was the 5% sheep blood agar, and so you can see some growth coming up on those plates, although the colonies are too small at this point for the laboratory worker to really work on them. And there's a little bit of growth on this CNA plate, nothing going on this plate, or this plate. So day 1, we just look mainly, and we can't really do very much. Everything's too small, nothing you can work on, but you can see that things are growing. So day 2, things are beginning to happen. So over here on the chromogenic agar for Staphylococcus aureus, there are some green colonies. Unfortunately, those are not Staphylococcus aureus, so the technologist is not going to work on those. But now there are some colonies here on the blood plate and on the chocolate plate that you can see, and these are isolated colonies, pure cultures of an organism. So in the patient sample, maybe there was one bacteria that landed at this point on the plate, and now that one bacterium has multiplied 1,000,000 billion times to form enough bacteria that it's a colony that you can actually see, and they're all clones of the same original mother, and we can work with that organism, isolate it, identify it, and try to figure out, is it an important pathogen, yes or no. Here on the CNA plate, only the gram-positive things are growing, and looks like maybe some white colonies here might correspond to these colonies over here on this plate. And these colors and what grows on what plate and how big the colonies are and whether they are hemolytic on the sheep blood agar or not, all those things are taken into consideration by the technologists to determine what tests they need to do to further characterize these organisms. So that's day 2. Here's day 3 on that particular culture. So we're missing a plate now, and that's the chromogenic agar for staph, because it didn't grow any staph, and it only gets a couple days to show up those staph, so we throw that one away, but we still have 5 left, and we're continuing to hold these plates to see if something won't come up a little bit later. And here's day 4, and still we have better growth on some organisms, nothing happening on some of these other plates, but we have to continue to hold it. We hold them 7 days, 5 days, 5 days. We have 3 laboratory technologists here from the microlab. They're very interested in you all, and they're here to support the work that we do in the microlab. And they helped me by saving cultures, and some of them took pictures for me of the cultures every day. Because that reminds, yes? You have a question?
No, it's just great.
Yes, it is great. And that reminds me, I had told Carol I was going to make one other little announcement about myself before I started speaking, and I totally forgot. And that is, I am not there in the laboratory every day. I don't even work there anymore. I'm retired, and I have another job as the Director of Medical Affairs at a high-tech molecular diagnostic company in Sunnyvale called Cepheid. So in the interest of conflict of interest, please realize that I am working at a company called Cepheid now. I'm still consulting to the laboratory at Stanford. I'm still teaching in the med school, etc. I take call, but I'm not there. So thank you to the technologists who took the pictures for me. Now let me tell you a little bit more about some of these interesting agars that we use. This is the chromogenic agar for Staph aureus. And you see there's some blue colonies in there and then these beautiful pinkish mauve, we call them mauve colored colonies. So that is the color of Staph aureus. So if we see a Staph aureus on this plate, we know that it's a Staph aureus, and we can then do the susceptibility testing on it and find out what antibiotics the patient will respond to for that organism. These are the Burkholderia cepacia plates, and this is a positive control. This is a negative plate. I don't know. That's not exactly how they're supposed to look, is it? No. Maybe the audience doesn't know, but I know. Anyway, these are the plates. I'm going to show you another picture of BSEP later, and you'll see that it's actually pink and not yellow. But we do have these selective agars. here's a typical culture plate from a cystic fibrosis patient that is mixed with a fungus or a mold. That's a fuzzy colony, and then we have to keep that plate closed and taped up because the spores of the mold, this is the same kind of mold that might grow on bread or fruit if you let it sitting around too long in your house. And when you open the plate, the spores could be breathed in by a technologist, and that's not safe. So as soon as we see mold growing, we have to tape the plate up together, and we can't open it again unless we open it very carefully in a biological safety cabinet. Here's a typical plate from a patient with cystic fibrosis that is mixed with a mucoid Pseudomonas organism, and you see this very gloppy, shiny colony. I think this plate actually has mold as well. I think it's from the same patient. And so these make the plates difficult to work with. A lot of painstaking care goes into making sure that we have a pure colony of the organisms that we can identify and work with further. Here's what a Haemophilus influenza looks like on a chocolate agar plate. Small gray colonies with very typical morphology, and then we go on and identify them. Here's a different plate from a cystic fibrosis patient showing another mucoid Pseudomonas aeruginosa. Now this plate, the McConkey plate, we use the characteristic of the organism that it is pink on this plate, I mean pale pink, not dark pink, which tells us it's a non-lactose fermenting colony. And on here you can see there's been clearing around the growth of the organism of the blood. That we call that hemolysis. You can see the clear zone of hemolysis around these colonies, and you can also see that these colonies look colored a little bit greenish or purplish, and that's typical of the Pseudomonases that we find from patients with cystic fibrosis. Now, once we see colonies growing, each individual colony that looks different on the plates, and if you recall, there could be 10, 15 different kind of looking colonies on each of those plates. We do a gram stain. And so here are gram stains of non-fermenting gram-negative rods like the Pseudomonas and shorter, fatter gram-negative rods like an E. coli perhaps or a Klebsiella. We look at those through the microscope, and then we do some spot tests, and we can do biochemical identifications using either a manual method with a lot of different colored reaction tubes based on the enzymes produced by the organisms, or we can use two instruments, automated machines. And our laboratory at Stanford has both of these two kinds of machines. This one uses a card where we make a dilution of the organism and suck it down into all these little wells and stick it on the machine, and it looks for turbidity and color changes in the various wells, kind of like this, but very miniaturized. And this one, the wells are bigger. You can actually see the different color changes on those wells, but the machine reads it automatically. Now, these machines both do an identification of an organism and drug susceptibility testing of organisms, but the mucoid Pseudomonas species that is so common in cystic patients doesn't work very well on these machines, and so we often end up using a manual method for susceptibility testing of those organisms. But we have to take special considerations when we're using the organisms with any of these systems because of the unusual nature of the cystic fibrosis non-fermenting organisms. The systems may not identify them as well, and we use other methods. In some cases, we send them to John LaPuma's lab in Michigan. You all know his name. We used to send them sometimes to Lisa Saman in Columbia to do more advanced kinds of molecular testing or synergistic testing. Yes?
How do you separate the bacteria from the agar?
Ah!
Like a pellet?
Okay, so say we wanted to pick one of these colonies off this chocolate agar plate. We have sterile plastic sticks or loops that we use to pick up that colony. And then we can emulsify it in a broth or subculture it to another plate so that it's totally pure, and then use another sterile plastic loop and just wipe up a whole bunch of it and then put it into a liquid and make a suspension that we can actually see turbidity, and then we can inoculate drops of that onto different medias and things like that. Right.
So potentially the little colony that you're sampling might be a little different from the colony 2 inches left of it?
You know, we encourage the laboratory technologists, especially the older ones like me who can't see very well, to use magnifying glasses and We have special magnifying glasses at every bench so people can look very, very closely at those colonies and make sure that they only pick one when they're working with the organisms. And if you pick two, if you pick one and maybe there's another little one growing underneath it, and the next day your subculture, you can tell it's mixed, it's not pure, then you have to stop and start all over again. And all the machines will tell you if it's mixed. They will give you an unclear result, and the susceptibility results won't make sense. And so that's an excellent question. A lot of brain work goes into interpreting what we see from our culture results, because the results that don't make sense, only a very experienced technologist will realize that the reason that susceptibility pattern looks like that is because it was mixed in the first place. We need to start all over, re-separate them all out, and go again. That's another time waste for you all waiting for your results, but we don't want to send a poor result out. We want it to be correct. So we will redo it if there's a problem. And obviously, with these kinds of mixed cultures, and with this very mucoid Pseudomonas growing on top of all these other little colonies underneath it, it makes it that much more difficult for us to pull those separate and work on them independently. But you have to, because you cannot give an antibiotic result when you have mixed cultures together. Each antibiotic has to act only on the one organism to tell us if it's resistant or susceptible to that. So the important pathogens in cystic patients are, of course, Pseudomonas aeruginosa. Some of them are very metallic looking, silvery. Some of them are very hemolytic and green, like this one. And mainly in the cystic patients, they're very mucoid and shiny, and they have this almost like sugar coating on them. We use oxidase, a rapid spot test, to help us be certain that they are Pseudomonas aeruginosa. They also have a particular smell. It's actually a very good smell. Most people think it's good, I think. But it smells like Concord grapes or like corn tacos. And so we use the smell, the colony morphology, to help identify the various organisms. going on there? That's a great question. Are we back online? Thank you. We just had a very interesting question about the patterns of the growth on the plates. So this growth pattern like this is one kind of growth pattern, and this one was made by a human person. So the sample was placed here on the Petri dish, and a plastic loop was used to streak that sample out into quadrants to isolate the colonies at the end so that we could work with them later. And that's one way that we inoculate and streak out our Petri dishes. But Stanford is very happy to have, and I'm going to go back and show you a different plate that, let's see, I can find one. Here. Yeah. So this plate was streaked by a machine. So we have an instrument, an inoculating instrument, where we place the sample on the plate at a certain place, always at the same place, which has a mark on the back of the plate, and we put it in a big machine, and the machine streaks it out for us into separate quadrants using a series of combs. And the machine, for sure, does a better job streaking than the humans do, and it saves us labor and time in the laboratory. So thank you for asking that question. So this is Calcifluor. It's a fluorescent brightener that we use to highlight fungal elements in original samples. And here you can see the fungal hyphal elements, tubules, and the septate separating the different cells of this fungal growth much more clear than you can here in the wet preparation that doesn't have any special stains on it. Now, the growth of a mold on a plate looks like this, kind of fuzzy, and here's the mold growing on the blood in the McConkey plate that we set up for the bacteria. We sort of don't like that to happen because then we can't get to the bacteria underneath the mold. We do like the mold to grow on the fungal media that we set up. So here's a dematiaceous mold, or a black colored mold, growing on one of the special fungal plates that I told you about. And here's what a yeast looks like growing on the special fungal plates. This is Chromager candida. It has different colors for different kinds of yeast, different species of yeast. And then this is the Stanford potato agar, plain old agar, special for fungi that doesn't have any color agents in it. So again, these are identified using morphologic methods, biochemical methods, all the different methods that we use for bacteria, but they sometimes take longer to grow and are more difficult to identify. It's a little bit more subjective. The person has to actually know what they're looking at to identify them. So let me move on to acid-fast or mycobacteria. The mycobacteria are pathogens in the cystic fibrosis patient. And these are acid-fast organisms. They are bacteria, but they have a special cell wall composed of fats and lipids, and those fatty acid cell walls need a special kind of stain to show their true colors, and that's called an acid-fast stain. So that's why they're called acid-fast bacilli. So here's the sample. The first thing we do is decontaminate it with sodium hydroxide and liquefy it with a mucolytic agent. So this is sodium hydroxide, mucolytic agent. And then we neutralize and dilute them with buffer after they've sat for a certain amount of time to dissolve all the mucus and kill off the regular bacteria. Now, with cystic patients, the regular bacteria includes those mucoid pseudomonases, which are really hard to kill. And so we have to treat these samples more harshly with more acid and for longer time periods to kill off the normal flora of a cystic patient in order to try to recover the acid-fast organisms that might be lurking underneath the normal organisms. The acid-fast organisms take a lot longer to grow, and so you need to get rid of the regular ones first to allow those other ones to grow up. So we inoculate them onto plates, and then we inoculate them into tubes of media. So here's one of the tubes of media that's growing an acid-fast organism, and we also perform an acid-fast stain on the sediment from that decontaminated sample. And the growth on solid media takes anywhere from 2 weeks to 30 days. This is what Mycobacterium tuberculosis looks like. This is what Mycobacterium avium intercellulare group looks like. This is Mycobacterium gordoni, which is not a pathogen, but we do recover it because it's in the water that we're all drinking. This is what the acid-fast stain looks like. So once we get a colony growing on our various media special, we then have to stain it to make sure it is acid-fast, and then we can identify it using either molecular methods in our laboratory or biochemical methods. And we do susceptibilities to the acid-fast organisms using an automated instrument called a midget, and the organism is growing in tubes containing various antibiotics, and then when it grows, it will fluoresce because of different special markers that are in this medium, and the machine will read the fluorescent, and that takes another week or 2 weeks. So total could be a month or longer. Now, let's talk about susceptibility testing for the bacteria, which are the most important pathogens in the cystic patients. Our laboratory must follow a guideline that is produced every year by the Clinical Laboratory Standards Institute, CLSI, called Performance Standards for Antimicrobial Susceptibility Testing. Every year this gets revamped, redone, revitalized, and changed. And they have tables here that tell us what organisms and what antibiotics we can and cannot test. So for Pseudomonas aeruginosa, for example, for the primary group, what you can see is ceftazidime is the cephalosporin, gentamicin and tobramycin, piperacillin. Those are it. We can move down to amikacin if we need to, and the drugs aztreonam, cefepime, etc. But if the organism is not on this list with these drugs, we cannot test it. And if the drugs are not on the list under this organism, we cannot test it because there is no interpretive criteria available to help us understand what that test means. And so here are the restricted antibiotics for Burkholderia cepacia. And what you see is there's only a very few antibiotics here that we're allowed to test. And then this tells us what the zone diameter breakpoints are for the inhibitory zones and the MIC, the minimum interpretive standards. And if we don't have that on our list, we cannot test it because we have no way to know what the results are supposed to be. This table tells us this zone, I'm going to show you what that looks like in just 1 second. Okay, so here's an antibiotic disc, and here's an organism, Pseudomonas aeruginosa, that's spread on the plate, and around the disc you see the organism cannot grow. It's called a zone of inhibition. Does that make sense to you? And we measure the zone of inhibition with a millimeter ruler by hand. And then we come back to here and we say, okay, if the organism is greater than 21 millimeters, it is susceptible. And if we don't have those numbers, we have no idea what a zone means for an organism. So we can't test it. Now we have 3 methods of testing. One is the discs, like I showed you. One is the minimal inhibitory concentration, where the antibiotics are in these wells diluted out. So really high concentration of antibiotic in the first well, we dilute it 1 to 2, 1 to 4, 1 to 8, 1 to 16, 1 to 32, etc. So way out here, there's not very much antibiotic, right? And way out here, the organism is growing. But up here in the higher concentration, the organism is not growing. So for each antibiotic and each organism, there is a special well where it's called the break point, where if it's growing up in here, it's resistant, and if it's not growing up in there, it's sensitive or susceptible. And so each one has its own special number. And a version of that quantitative susceptibility result is something called an E-test, where the gradient of antibiotic is on a plastic strip. High concentrations up here, low concentrations down here, and what you see is the zone of inhibition of this Pseudomonas is like an ellipse here, and we can read the concentration of antibiotic that's going to kill it right here off the score on the front of that thing. Now for fungi, we use only the broth inhibitory concentration method, and in this case we have a color indicator to help us look at where is it growing, where is it not growing, where is the threshold that we can call it susceptible or resistant. Now it's kind of clear cut here that it's growing in the pink one and it's not growing in the blue one, but look at the next row here. That's kind of a pinky blue, isn't it? So you can see that these things are slightly subject to somebody's subjective judgment, and we spent a long, long time training people so that we all read them the same and that we interpret them the same. And this method is only used for yeast And if it is a mold, we have to send it out to a reference laboratory because we don't have a method for testing molds at this time. So that takes another week or two till you get an answer. So, reporting results. Some we call, because they're very important, some resistances, some organisms, but all of them get placed into the computer. So here is our susceptibility expert person sitting with a pile of plates, and she's going to input the information into the computer, and then that goes to the laboratory information system for interpretation, and then to the hospital information system where it gets sent out to the physician and the caregiver. So this kind of microbiology is the most labor-intensive analysis that we do in the microbiology lab. The average hands-on time for one sputum, I've clocked it myself, we did this time study, 2.5 hours. The average for another kind of culture, sputum from a regular patient, 15 minutes. 2.5 hours, 15 minutes. The time to final results, if it's a very simple thing, 4 to 6 days. For bacteriology, 2 to 4 weeks. Mycology, 4 to 8 weeks. Acid-fast bacilli. It takes a long time to go through all this, to get those things to grow, to work on them, to get it right, and to report it. But we really care about our cystic fibrosis patients, and here's Dr. Niaz Banai. He is now the director of the Clinical Microbiology Laboratory. These are just some of the technologists. You see some others here, Nancy and Cheryl and Manju, and I want to thank you all for your interest in what we do in our laboratory. Thank you. Yes, question.
Can you explain the difference between a yeast and a mold?
Yep, I will. And it's pretty simple. Okay, yeasts are smooth and flat and round, and molds are fuzzy.
Like on your bread.
Like on your bread, or, you know, the ones I really like are those purple fusarium that grow on your strawberries if you leave them sit around too long. Yeah, those ones. Those are killers in your humans, but they're killers on the strawberries too, right? Yeah. Yes?
Can you explain, if, in terms of a threshold, if you have one colony for something, when is it clinically significant versus if it's more than one colony? Do you have a certain threshold when you call it?
For the mucoid Pseudomonas, correct me if I'm wrong, if we even saw one, we would call it on a cystic patient. We would work it up, exactly. Our technologists know the difference between the normal organisms that everybody has and the ones that are potentially pathogens, actually. And so normal ones like alpha streptococci that everybody has, and there are things like coagulase negative staphylococci, Neisseria species. There's many coriniform rods that are not known to be pathogens. Their colony gives them away, or at least once we gram stain it and do a few simple tests like that catalase test, gives it away, and we don't work on it anymore. But any single thing that could potentially be a pathogen on a cystic patient, if we can get it out of there, we're going to work on it. Yeah?
Another question. When we get the reports back, they say things like 1+, 2+, 3+.
Mm-hmm,
Can you explain the difference?
Yeah, thank you for asking that. Okay, so we streak these plates in quadrants. Even the machine streaks it in 4 different sets of diminishing numbers of colonies on the plate. And so this is the first quadrant, this is the second quadrant, the third quadrant, and down in here is the fourth quadrant. So if there's only growth up here in the first quadrant, it's a 1+. If it grows into the second quadrant, it's a 2+. If it's out here, it's a 3+. And if it's all the way filling up the entire plate, it's a 4+. So it's what we call a semi-quantitative result. I don't know that it makes any difference. Let me just give you an example. Say we're talking about gag sputum. You all know that's a swab that is placed at the back of somebody's throat who's not coughing. And in cystic patients, and we do not accept those from any other kind of patient. They mean nothing in any other kind of patient. But in a cystic patient, the organisms colonizing the respiratory tract often are found at the back of the throat. And so we can see if there's the mucoid pseud there or whatever. So we will accept a gag sputum from that kind of patient. Well, what if the physician just barely touch that swab to the back of the throat, we're not going to get very many organisms on the plate. If they do a really big one, makes you really feel terrible, and that's a really good sample, then you'll get a whole lot of them growing on the plate. So I'm not so sure that the relative quantity is all that important in this kind of sample, but we do report it for physicians' information. And sometimes we make decisions based on relative quantities. So if there's one colony, one organism, and 5 different ones that are way more, we'll do much more work maybe on all those 5 that there's more and not so much on the 1. But we will report its presence 1+. Yes, other question? No, that's
Do
great.
you treat a sputum sample any differently if it's from a CF patient pre-transplant versus post-transplant?
The pre-transplant versus post-transplant cystics, it really depends on the physicians. You know, some of your physicians want to say, and frankly, I think this is incorrect, they want to say that post-transplant, they don't need to order CF respiratory anymore. They want to order a regular old respiratory sample. But guess what? In the laboratory, we're growing those same organisms, oftentimes, that we saw pre-transplant. So if they would order it as a CF respiratory, we would have set up those other special plates that we would like to be setting up. So I believe that once a cystic, always a cystic. I think you should always order CF respiratory. If the weird things aren't growing, they just won't show up on our plates. But at least we have those plates there, and we can look for those organisms. Other questions?
Yeah, we have a couple of questions here from the online community that are chomping at the bit to ask you some questions here. Let's see, one was, why do some clinics treat staph A and some do not? Do you feel that if no symptoms are present, one should be on antibiotics?
Well, those are good questions for Dr. Sisodia, and I will
Okay.
let him take those when he gets up here. I'll introduce him in a minute.
We get to another one then. Let's see, I have a question about Toby. I have only ever tested positive once for Pseudomonas, yet I'm prescribed to be on Toby every other month. Is it necessary to be on it all the time?
Deepak, that's going to be yours
Okay.
too. I am a microbiologist. I'm a PhD microbiologist, not an MD physician. And one of the things that we all have to be very careful to do is not step into each other's realms.
Let's see, how do you know when the culture is done growing?
Good question. I think after 5 days, we've had a lot of time and experience that after 5 days, nothing new is going to show up that we haven't already seen. So we've determined over the years from holding them longer, I think 7 days in the old days, but we found that 5 days was enough. So that's how we know. After 5 days, we are done. Yes?
If you have different strains, do you know that because the colony formation is different? Or is there any-
Different species, different genera, we certainly can tell. But if we had 2 different coagulase-negative staph strains, for example, on a plate, they would look alike, and we would not be able to tell them apart. But most of the Pseudomonas aeruginosa strains that patients have, they look different. And many patients have more than one, and the colonies do look different. So the rule is, if they look different, they are different. If they look the same, they might be different. So we will work very hard to try and make sure that we don't miss anything. And remember, we have all those different colors of media. And so they may look different on one plate, like the blood plate, but they may look slightly different on the chocolate plate or slightly different on the CNA plate. So all those plates help us to pull out the different strains or genera of organism that are present there.
Okay.
Go ahead.
Oh, I was going to ask about Achromobacter. Is that the same as this guy?
No, Acinetobacter is different from Achromobacter. Achromobacter is yet another non-fermenting. I did not show you all zillion of them. Yeah, there are lots. Right, right.
One more question. When a physician sends a sample and they ask for sensitivities and
Culture.
culture and sensitivities, and it's been only a short time since the last sample,
Mm-hmm.
how can you decide whether you need to redo the sensitivities or not, or just report the last sensitivities? How often do you think?
You know,
that should be
that's a
done?
great question about how often do we do the susceptibilities from the same patient. And we worked that out with Dr. Rick Moss a number of years ago, and we made an agreement that we would do, I think it's every 3 months, we will redo the susceptibilities on the organism from that patient. Our technologists who work that respiratory bench, we're very blessed to have a very stable crew of experienced people. They basically know the cultures from the different patients that we get and the different organisms. They recognize the colonies. They could tell you who the patient was by looking at the plates. And they will know, they always look up in the record, though, when was the last time we sent out that susceptibility. And so if it's been 3 months, we'll send it out again. Yes, question?
There are some people with CF who can't produce sputum.
Right.
So they're just given a cup, told to go home and bring it in when you can.
Mm-hmm.
And I've heard of people who've been told, put this in the fridge if you can't make the drive right away. Just putting it in the fridge, like, kills some of the bacteria. And make it false
That is a
positive.
great question, is how should you store that sputum if you can't bring it in right away? Ideally, we'd like to have it within 2 hours. That would be our best possible scenario. If you can't get it to us within 2 hours, put it in the fridge. But some bugs are going to die. Streptococcus pneumoniae is going to be dead by the time we get it if it's sitting around in the fridge for 5 hours, for example, and we'll just never know it was there. So there are, the Haemophilus influenza is fairly fragile as well. It may die, even in the fridge. So you're right. It's ideal would be direct. But it's never going to be totally direct because it has to go to the hospital through the courier to our laboratory to our accessioning. Yeah. Yeah, question.
This might be a borderline clinical question. Many people with CF are breathing antibiotics, so.
Correct.
So how do you work that?
We don't take much of it into consideration, the fact that they're taking aerosolized antibiotics. If the organism is resistant to the antibiotics and not responding, it will grow, and so we will recover it. So it's kind of a good test. If the antibiotic is working, we won't get that organism growing in the laboratory. Sometimes we see a phenomenon called the antibiotic effect, where the organism will be growing on the end of the plate out here, but not right here in the middle where the sample was placed, and that's because the sample contains antibiotic and it'll kill it, but by the time the antibiotic's diluted out to here, we will see the organism growing. So we will sometimes see that. But it's just something we have to deal with. We don't have a method to remove the antibiotic or inhibit its activity in the sample when we get it.
But do you have is there some notion if somebody doesn't inhale an antibiotic for, let's say, 12 hours, would that be long enough to rule that out, that problem?
Boy, I don't know. Deepak? I don't think 12 hours would do it. I think a couple days might do it. But there's a lot of residual antibiotic effect. Antibiotics, they have a high concentration, and then it goes down very slowly over time. So each antibiotic has, I know, but they're sitting there, on the surface of the mucosa. They're adsorbed onto the surface, and so I think there's still a kind of a fade time for them, and I wouldn't know what it is, and it might be different for different ones. Exactly. All right, well, let me turn it over to Deepak Sisodia. He is PharmD, Doctor of Pharmacy at Stanford and manager of the Stanford Pharmacy, and he's special interest and expertise is in antibiotics. He's been managing our antibiotic committee at Stanford for a number of years, and I'm very delighted to have him here with me. Okay.
I'm sorry, David, you remind me again how to get to...
Is it down on the bottom there? Yeah, it's the other one that must...
This one?
Let's just see if we can get out of this. It's right here.
Ah, there we are. All right. Let me just find my pointer and I'll be good to go. So I get the unenviable task of following Dr. Barron. I'll tell you honestly, in our antibiotic meetings at Stanford, I would intentionally put myself ahead of her in the agenda, and I can see for good reason why now. That's going to be a tough act to follow. So I'm Deepak Sisodia. I'm a pharmacist at Stanford Hospital. My role has slightly changed recently, but previously I was a practicing pharmacist on the floors, and one of the units I covered was a medicine unit, which does get a lot of the cystic fibrosis patients. I'm very excited to be here tonight. This is a topic that I'm very interested in, and I have to admit, when Camille approached me about doing this presentation, I was a little skittish because, as most pharmacists, we tend to be a little obsessive compulsive, and we tend to our minds race a mile a minute. So I'm trying to think, how in the world am I going to condense 4 years of pharmacy knowledge into a 20-minute spiel? But she gave me very sage advice and said, just keep it simple. And with that, I hope to accomplish that endpoint. So, objectives for today, I thought I would take the approach of kind of going over the drug classes that we commonly use in the inpatient setting. So what are the drugs we're using on the hospital side for the cystic fibrosis patients? And then, more specifically, what are the common therapies that we use for certain common pathogens, specifically the Pseudomonas aeruginosa, MSSA, and MRSA. And Dr. Barron did a great job explaining how those pathogens are identified through the lab services. I'll also spend a little bit of time, I think one of the online questions was about inhaled antibiotic therapies, but I'll talk about some other treatment modalities, inhaled antibiotic therapies being one, and also the use of mucolytics. And I'll wrap up by talking about some of what I perceive to be the hotter topics in the realm of anti-infective therapy for cystic fibrosis. Okay, so I'll start off with the class of drugs called aminoglycosides. So as you can see, I have a chemical structure here, and by no means do I intend this to be a chemistry lecture, because I'll be honest, it was a class I really did not enjoy myself. But, but what I'm trying to share with you is the complexity and nature of these drugs. They're very, very unique and very hard to come by. To give you some perspective, I recall from my days back in pharmacy school, and this was not to date myself, but this was just at the time when internet was coming on, so we still had a lot of paperwork and stuff in our lectures. And one of our lecturers described the drug development process. I won't go into detail about that. That's a whole lecture series in itself, but he encapsulated it as stating as such, to bring one drug to the market, you could fill an airplane hangar with the paperwork. I find that a little hard to believe, but I think the point being taken, it's a lot of work, a lot of dollars, a lot of years, a lot of trials, but just to get one drug to the market. So I'll have a lot of chemical structures up here just to show you how complex they are, and they're by design. There's a lot of trial and error to get those to work and make it to our use today. So back to aminoglycosides. These drugs have been around for several decades. There are many different types in production, and we really use primarily just 3 in the U.S. for cystic fibrosis, and those are the 3 listed there: gentamicin, tobramycin, and amikacin. The first 2 are more prevalent in the adult population. Amikacin is slightly used more in the pediatrics, although those certainly can cross over. Sorry, I have MOA written up there. What that means is mechanism of action. Basically, how do these drugs work? So aminoglycosides, they inhibit bacterial protein synthesis. They get involved in the ribosomes and do their thing, basically killing off the bacterial cell itself. And spectrum, what that refers to is what do they cover? I mean, what are they good for? So aminoglycosides are particularly good against gram-negatives. So one particular bug of interest for cystic fibrosis is the Pseudomonas strains. So how do we give it? Well, aminoglycosides, unfortunately, are not very well absorbed when you give it orally. So, aside from getting a stomach ache, you're not going to get much benefit from giving a drug by mouth. So we rely on what's called parenteral administration. Parenteral basically means we're giving it intravenously or intramuscularly. Intravenous is the more prevalent approach. These drugs are dosed based on the weight of the patient. You give a certain amount of milligrams based on the patient weight. So everyone gets an individualized dose, so to speak. There's not a flat dosing. Now, exactly what that dose is, like I mentioned, it's kind of dependent on the weight of the patient. But also, there's 2 different ways of giving it. There's what's called traditional dosing, splitting the dose up several times throughout the day. And there's also the once daily administration. That's more of a newer concept that's being used. And I'll explain that graphically in just a second here. And in terms of course, like all drugs, they do a lot of good things. Unfortunately, they do carry some baggage as well. So 2 notable things with aminoglycosides is their ability to negatively impact your kidney function and as well as your hearing ability. Now, I'll make a few quick comments about that. Good news is there are some ways to measure that and detect for that. Renally or kidney specific, we can actually do drug levels Again, I'll explain that in a second, but also check patient levels as well, patient-specific labs to assess if that damage is occurring. With the hearing situation, it's not quite as defined, but there are some tests we can use, some autometric tests that can help determine if any of that kind of damage is occurring. So what I have here, so I work better visually, so bear with me, I'll have a lot of graphs throughout this presentation illustrating some things. So what this is a graph representing concentration versus time. You have drug concentration on this axis here, and the time spreading out here. And the conventional regimen, which I described as the one that we split up multiple times throughout the day, is represented by these lines here. So essentially what is happening is you give a drug, or give the drug, you get a spike in the blood level, and over time, as Dr. Barron described, the drug kind of goes away until you give the next dose. And like I mentioned with traditional dosing, we do this about 8 hours apart. So if you were to measure blood concentrations of an aminoglycoside using traditional dosing, this is kind of what it would look like. You get a spike, goes down, spike, goes down. Once daily, as I described, slightly different. We give a larger dose up front, and you get a really high level, and then throughout the day, that drug level just keeps going down and down and down until it gets way down here. Now, what are the differences? Well, in terms of efficacy, what we look at is what's called the peaks. Those are the highest level the drugs attain. So these are the peaks for the two treatment regimens. They don't have to be at the same level, so to speak. Traditional dosing, we shoot for levels roughly about 5 to 10, depending on the severity of the disease, but for cystic fibrosis, we tend to shoot a little higher. But that's kind of the realm we shoot for. Once daily, if we were to measure peaks, those levels tend to be a little higher, and you can understand why, because you're giving a lot more up front at one time. Those levels, if you were to actually get them, would be in the 20 range. We usually don't recommend this because you kind of guarantee you're achieving those levels by giving that much drug in advance. You don't need to draw a level to determine that. For the once dailies, the conventional dosing, we still want to check level to make sure we're getting the right target. Now, that tells us the drug is working. Now, as I mentioned, there's ways to tell if the drug is hurting you. So what we've found is that there is a magic number for that, and that level seems to be about the concentration of 2, so to speak. So what we shoot for when we are checking the lowest levels is levels less than 2. And that, hopefully, if we can attain that, not guarantees, but certainly increases the chance that you're getting an effective kill rate by giving it up here, and also minimizing the chance of the toxicity by keeping a lower level. Now with the once daily, it's slightly different. Sorry, I should have mentioned this was for the traditional. The once daily kind of drops down to, as you can see, next to nothing. And that is expected. Now, a question one may think is that a problem? I mean, you essentially now have a period of time where there is no drug present. And the answer to that, I mean, it's a very good question, but the answer to that, no, that's actually not a problem. Aminoglycosides have a unique characteristic. They exhibit what's called post-antibiotic effect, PAE for short. What that essentially means is the drug doesn't have to be measurable or detectable for it to be still having an effect. So what this is saying is that although you take a blood sample and you do not detect aminoglycosides, it's still in the bacteria working and having an effect. So with that, you can rest assured with the once dailies that if you were to measure, we don't really recommend the peaks, but we just look for this level down here, and for it to be undetectable, that's a sign that the drug is on the right track of working. Another class of drugs are the quinolones, and these are synthetic drugs that have been on the market for, I want to say probably since the 1960s, a few decades as well. And to be honest, there are many different types of quinolones. The predominant ones they use are what are called fluoroquinolones. And again, not to get into chemistry by any means, but basically what that means is there's a fluoride connected on the side chain there. And like I mentioned, there's many different types. There's roughly about 10,000 different ones that have been studied. But for cystic fibrosis purposes, we really just use 2, Cipro and levofloxacin. Like the aminoglycosides, they work kind of in this what we call concentration-dependent manner. However, there's no dose specific for each patient. There is kind of this flat dose that kind of works for everyone. Levofloxacin, for example, is kind of a 750 type dose. Cipro, if you're given IV or PO, fluctuates between 400 and 500. Unlike the aminoglycosides, there is no drug monitoring needed for these. That makes it nice and easy. And the good thing about these drugs, unlike the aminoglycosides, is they're well absorbed when given by mouth. So you could give it IV or you could give it PO. PO, sorry, being my mouth. So like all drugs, they do have some negative baggage as well. Most commonly is GI upset. But some unique ones for the quinolones are a couple that I've listed there. One is photosensitivity. This is particularly important. Well, let me backtrack. What this is the patient's skin becomes a little more sensitive to sunlight, almost like getting sunburned. And this is important because this is a class of drugs that we, as I mentioned earlier, are well absorbed orally, so they tend to be used a lot on the outpatient side. So important for patients to be aware of that and to take appropriate precautions, wearing sunscreen, sunglasses while being out, protective clothing, etc. In addition to that, there has been some concerns with what are called arthropies with quinolones, and basically that is the ability to affect joint or tendons. And what this originated from was actually the original animal studies with the products. They found that it affected animals, particularly younger animals, a little more. The human data is not quite matching to that, although the concern still exists in mind. So most practitioners will not use quinolones in the pediatric side unless they have to. Quinolones do have the capacity to cause another infection, actually, something called C. difficile. And what that is essentially is it kind of quinolones wipe out your normal flora in your stomach. And then this pathogen grows. And the problem with this is it causes a pretty profound diarrhea and makes patients very ill. So it's a whole disease state in itself. There has been some association with the use of quinolones and the expression of C. difficile. So that is something to note as well. So unlike the aminoglycosides, which were limited to just Pseudomonas or gram-negatives per se, quinolones kind of have a broad spectrum. They work against many different pathogens. For CF, the ones of note are Pseudomonas again, and can be used for the Staph aureus, both MSSA and MRSA, although they're not really first line for that. Okay, so beta-lactams. Now, beta-lactams is really an umbrella of classes. It's not just one class of drugs. It covers a whole bunch. It's a whole family, so to speak. So of that included are the penicillins, which are the likes of, you may be familiar with some of these names, nafcillin, piptazorzosin, ticarcillin, which goes by timentin. Also included are the cephalosporins. Those are, again, sorry, I've highlighted the ones that we use for cystic fibrosis predominantly, although there are many more of these types. So cephalosporins, ceftazidime and cefepime. And these drugs, or these classes of drugs, are called beta-lactams because they share a commonality in their chemical structure. They have this little, as we call beta-lactam ring throughout. And that also applies to the other ones. And those are the carbapenems, those listed there, imipenem, meropenem, and more recently, the last couple of years, doripenem. Carbapenems are kind of the big guns. They really cover a broad spectrum of pathogens. So using those drugs is a shotgun approach, as we say, and very effective. So there's the structure for imipenem, and you can see that familiar little figure there. And lastly, there's aztreonam. Aztreonam, kind of like a red-headed stepchild in a way. It's what we call a monobactam. It's a little different. It's a structure that, as you can see, it looks almost the same, but if you look a little closer, it doesn't have that side fused ring to it that the other beta-lactams did. Why this is important? Because I'll explain a little bit, actually probably on the next slide, is one of the problems with the beta-lactams is the chance of allergenicity, where patients allergic to one, for example, a penicillin, the chance of being allergic to a cephalosporin or carbapenem increase as well. Aztreonam, with lacking that side fused ring here, that risk doesn't necessarily exist. There is a good chance you could use aztreonam without having to worry about the concerns of the cross-reactivity that you would with other classes. So, again, going back to, I'm a visual guy, to explain how these drugs work, it's a little different than the concepts we described earlier. So again, concentration up here and time here. Now, an important concept with beta-lactams, as Dr. Barron touched upon, was the concept of minimum inhibitory concentration, MIC. What this basically represents is this is the lowest concentration needed to visibly inhibit bacterial growth. So this is like the bare essential you need to minimize bacterial growth. And how beta-lactams work, essentially, is if you give the drug, no surprise, you get a spike in the concentration, and over time it kind of dissipates down. Now, as you recall with aminoglycosides, we talked about the level here is what matters, and down here and such. Aminoglycosides is not quite the same. What we're looking for is actually how long in time that level stays above the MIC. This is something called time above MIC, and that's what predicts beta-lactams working. So what we shoot for in beta-lactams is not necessarily that that time above MIC has to be there throughout the therapy. That's not the case. It has to be there for usually about 50% of the time. So that's a concept that really helped shape some of the novel treatment modalities we're using. I'll explain that a little bit later on. So some of the baggage with beta-lactams, of course, like all drug classes, antibiotic related, they have some capacity to affect the stomach, GI effects. And as I touched on before, the cross-reactivity with allergies. So this is quite problematic. As Dr. Barron was describing, you're quite limited at times what antibiotics we can use based on the sensitivity panels. So we do have the capacity to what we call desensitize patients. So patients that you don't have any other treatment options but what is listed on the lab, and unfortunately the patient is allergic to this medication. We at Stanford and a lot of other institutions do what's called a desense. And a desense in a short nutshell is slowly introducing very minute amounts of drug to the body in just enough where you allow a response, not in an immune way, but allow the body to get used to it, so to speak. And you slowly increase that dosage amount over a period of hours. So in our case, we will do this desense in about 4 hours, and for the most part, those tend to work pretty well. I'd say with my practice, about 10 years now, I think I can think of only 2 cases where the desense didn't work. So we use that quite frequently with a great deal of success. What the drugs are used for, like the fluoroquinolones, they have a broad spectrum, so a lot of gram-positive and gram-negatives alike, and I kind of listed a few of the ones there. Okay, so vancomycin. Now this is another drug that's been around a while, since the 1950s. Now this drug actually has a pretty neat origin. It comes from the jungles of Borneo. I find that actually quite fascinating that we have drug development occurring across the world like that. But I don't know if any of you ever saw the movie with Sean Connery, Medicine Man. I think it was in the late 80s, if I recall. That concept of him in the jungle, the Amazon, trying to find a cure for cancer. When I read that vancomycin originated from Borneo, that picture came to mind, and thinking of this drug investigator with a machete going through the jungle trying to find some cures. I'm sure that wasn't the case, but. So vancomycin has been in use for roughly over half a century and going. It is a very heavily used drug, and its spectrum, as we say, is really just limited to gram-positives, really more specifically for MRSA, although it does have the capacity to be used for others, MSSA included. So back to our graph again. How does this drug work? Again, this is a parenteral drug only. It doesn't work well orally. It is used orally for different indications, kind of the C. difficile disease state we talked about earlier. It's used for that, but that's just because it only works in the stomach, doesn't really get absorbed into the bloodstream. But for our purposes of discussion today, the vancomycin we give is IV. It's a weight-based dosing, so kind of like the aminoglycosides, depending on a patient weight, you may get a different dose. And what we shoot for here is actually a specific target, and these are based on published guidelines. So what this illustrates is, over time, repetitive doses kind of looks like this if you were to draw blood concentrations. You get this kind of creep upwards, but then it kind of levels out. So what occurs at this point is you reach a point called steady state. And what that essentially is saying is the amount of drug coming in is essentially the same as going out. So even given more and more doses, how many days out, you're not going to get much more of a concentration up here or much less of a concentration down here. You kind of reached a level point. And how that relates to vancomycin is we look at the bottom part, what's called the trough. Trough meaning the lowest point that the drug concentration reaches. And based on the guidelines that are published and the way the drug works, we shoot for levels, or trough levels, for about 15 to 20. And it sounds reasonable enough, and that actually works for most patients. Now, one unique characteristic with cystic fibrosis patients is they have a unique ability to clear drugs very quickly, particularly antibiotics. So the feasibility of attaining a trough level of 15-20 is very challenging in CF patients. To give you some perspective, a typical dose for most patients is maybe 1 gram twice a day to achieve a target like that. With CF patients, we've gone to doses of 4 and greater a day, 4 grams and greater, almost threefold what we normally would. And sometimes do not even achieve double digits, let alone a goal of 15 to 20. So point being, it's a little difficult to achieve that target with CF population. That's not always feasible, so we have to look at other treatment options. One of those being linezolid, or Zyvox. Linezolid is a synthetic drug that's only been on the market for roughly about 10 years now. It is what's considered flat dosing, meaning the same dose applies to all patients, 600 milligrams BID. It has 100% bioavailability. Now, what does that mean? That essentially tells you, given the drug IV or PO, you're going to get the exact same concentrations. So that's a good thing to note because patients that you're not necessarily tied to an IV for the whole therapy. You can actually continue your care outside, and getting it by mouth, you can essentially guarantee you're going to get the sustainable levels like you would via the IV route. Like vancomycin, it's limited in its spectrum to the gram-positives, MRSA specifically. For the most part, it's actually really well tolerated in the short term. GI effects, there is some concern for drop in platelet counts. Aside from that, there are cases where you do have to use a drug for longer term. And in those instances, there are a couple of noticeable adverse effects that we wouldn't really see in the short-term phase. And what those are is the risk of neuropathies. That's something that essentially basically means a change in your sensations. And also the risk of lactic acidosis. Basically, that's an acid-based disorder. So not to scare you off with any of that terminology, but basically what the recommendation is, if you're going to be on linezolid for a period of time, that they'll usually do weekly blood checks at points just to see how your body's handling. Okay, another oldie. We have colistin here. This came out in the 1950s as well. It's a weight-based drug with really just gram-negative coverage, kind of like the aminoglycosides. And this drug was heavily used in the early stages and worked really well. However, it kind of got replaced with the advent of aminoglycosides, and I'll get to that in just a second. But in terms of how we use it, kind of like the other ones, there's no PO option. It's just given by IV. There's also the inhaled route, but I'll talk about that in a second. That's used in a different scenario, so to speak, or different purpose. So colistin, why did it come off, or why did it fall out of popularity? Really, the two side effects it has, yeah. Some levity. It does have a higher risk of damaging your kidneys than aminoglycosides. Hard to imagine, but it actually does. And also the neurotoxicity, kind of those nephropathies we just talked about that are common with linezolid with long-term therapy. So for those reasons, it kind of fell out of favor and wasn't really used a whole lot. Now, that has changed a lot. Resistance to colistin, before I get to that actually, resistance in general, as Dr. Barron talked about, is very prevalent in the antibiotic, in the bug world. And unfortunately, that's the battle we're really losing. So with most of our antibiotics, and certainly the ones I've talked about, they all have potential to have resistance to it with the bugs that we're talking about today. Colistin, not so much, and really it's not for any good reason, with the exception of that we just haven't used the drug a whole lot until recently. So I'm sure that good luck will run out soon enough with the cases that we're seeing today. Okay, so to recap, Pseudomonas, and sorry, that slide is nowhere as pretty as Dr. Barron's slides. But the treatments we use are the ones that we talked about today. Some of the beta-lactams, there's a few options there. Aminoglycosides, fluoroquinolones, Cipro and Levo, and colistin. Those are kind of the mainstay treatments. Now, Pseudomonas does have some baggage with it. It's not just plain Pseudomonas. There's mucoid, which is this Pseudomonas strain that can kind of grow this little protective barrier around it that makes drug penetration very difficult to get through and a real bear to treat with. Also, the not uncommon, not specific to Pseudomonas, but it has a propensity to be multi-drug resistant. What that means is it's resistant to 2 or more drug classes. So, you know, 2 or more of the ones above would quantify a bug to be multi-drug resistant, and that becomes particularly challenging for physicians and clinicians to treat. So, Dr. Barron also mentioned the concept of synergy. So that is actually a novel concept. That is synergy in general. Like for drug therapies, what this refers to is you have 2 drugs being used together that you get an added benefit or a benefit greater than just adding the 2 together. And it's kind of hard to describe, so I use math to illustrate my point. So adding 2 plus 3 is 5, right? 2 antibiotics added together in synergy purpose doesn't quite equate that. It's more like multiplying them together. You get a greater benefit than you anticipate by just adding them together. So there are certain labs that can do synergy testing. That's not commonality in most of the labs. You can't just send it to Hillview here. I think we send them all to Michigan, is it now? Or?
Well, Lisa doesn't do them anymore, so I guess we send them to Quest. But we haven't found, you know, there has never been a good study that correlates in vivo response to in vitro results of synergy testing. So most of our physicians have agreed with us that the bang is not worth the bug or the juice is not worth the squeeze. So we don't send them anymore.
Thank you for that. So yeah, sometimes there were some concepts that it sounds like they've fallen out of favor, but the use of synergy dosing or synergy for identifying drug treatment modalities that could work for certain pathogens. So Staph aureus, like I mentioned earlier, there's two problem childs in the Staph aureus world. There's MSSA, which is essentially methicillin-sensitive Staph aureus. And what this is you're more, I don't want to say easier to treat, but you have more options to treat with. Basically, the likes of the beta-lactams, nafcillin, your cephalosporins. That weird little acronym there is actually Bactrim or Septra, and rifampin. Rifampin is not ever used on its own. It's usually an add-on agent with other drug therapies. But point being, with MSSA, you have more treatment options than you would with MRSA, methicillin-resistant Staph aureus. And what this is a Staph aureus that has the capability of breaking down beta-lactams. So all those treatment options we were talking about earlier don't really work against MRSA. And then you have to rely on the likes of linezolid, vancomycin. Septra still works in those cases. And luckily enough, for MRSA treatment, there is actually some newer options out there. Just in the last year, we've had 2 new drugs be approved by the FDA, telavancin and ceftaroline. Telavancin is very similar to vancomycin. It's once daily given in this case. Ceftaroline is actually a cephalosporin. It's what we call a 5th generation, so the 5th of its kind. But it is the first cephalosporin to have MRSA coverage, so that's kind of unique for it and exciting for us in the pharmacy world at least. So just to, again, highlight the point, there are treatment options that we use that do have what we call good oral availability, so not necessarily going to be tied to IV therapies for the duration. Those include linezolid, like I mentioned, has that 100% bioavailability, meaning it works just the same as PO and IV. The quinolones also have PO options that can be used, and rifampin as well. Rifampin, again, is not really used a whole lot with the exception for MSSA, although it does have roles in other indications. Okay, so I think one of the online users that asked a question about inhaled drugs, so I'll make a few comments about that. And the purpose of inhaled antibiotics is a little different than what we've talked about so far. So all the treatments we've been discussing to this moment have been kind of more in your hospital setting, your acute exacerbations, as we say, patients that are coming really sick at that moment in time. The inhaled antibiotics kind of serve a different function. They're not really there to treat, per se, that moment in time. They're kind of more of a controlling type drug. So they're often given, Toby being the first, and others that have been come on the market since, colistin, amikacin, levo, quinolone, it goes on and on. But basically the point of this is to give the patient a 4-week period of taking the drug and then a 4-week off. And what it's doing is, again, not treating the infection per se, but just controlling it. Because often in cystic fibrosis, you're colonized with pathogens, Pseudomonas staph aureus. And what that means is you can't ever really get rid of the bugs, so to speak. They're always there to some degree. And the use of inhaled antibiotics kind of helps keep them in control, so to speak, so they don't get to that point of getting really sick at one point in time where you have to go in for IV therapies and such. Yeah, please.
What about a younger patient who's just been infected for the first time?
Mm-hmm.
What about treating with inhaled at that point?
So it's a good question, one that there's no clear, I shouldn't say that, there's no clear school of thought of which way to interpret inhaled antibiotics in terms of systemic therapies. So, for example, Toby, it doesn't really get very good systemic levels, meaning bloodstream levels. Does that necessarily dictate that it won't work in those settings? Not for sure. There is some evidence behind inhaled colistin that it may be of use in those settings, but there have been no really clear-cut studies to show benefit one way or another. So if faced with that scenario, I would imagine most clinicians would opt to not use inhaled therapies, but rather opt for the more reliable intravenous therapies to get the intended result. Is that going to help?
Well,
I guess the idea of combining would never be.
So that's a good question. You mean combining the two of the same? So inhaled Toby? Yeah, that's question's been asked before, and again, no clear-cut answer about that. In my opinion, I don't see the harm in doing it, but I'm not sure if you're really getting much benefit. Because given a drug intravenously, you get that kind of spread throughout. It gets in really well. Conversely, if you're given drug inhaled, does it really get everywhere else? Not as well. And the data supports, as far as in terms of efficacy, certainly giving drugs intravenously over inhaled for those acute treatments, so to speak. We haven't, that I recall at Stanford, done that treatment, so to speak, but not to say it couldn't happen. Yes?
In my experience, I'm wondering if the 2-week course of IV or the 3-week, whatever it is, and the 4-week course of inhale
Mhm.
is somewhat arbitrary. I mean, is there actual evidence that you're going to kill off as much Pseudomonas maximally if you inhale it for 4 weeks versus 2?
So
Or
d-
BID versus, QD?
Are you speaking just with inhaled therapies alone? No, I mean, the published trials all looked at 4 weeks, so I think that's kind of the mindset that is used. To go from that, not to say you couldn't, but I think most clinicians would opt to stick with what's published to support. In certain settings, I guess you could try. Are you referring to maybe a 2-week on, 2-week off type scenario, or?
Right, I mean, it's just not proof that it doesn't work.
Right, exactly, exactly,
You
yeah,
don't
sorry.
want to develop resistance, and so you don't want to undertreat these organisms, because if there's resistance factors, even in a small subpopulation, you don't want to kill off the susceptible ones and leave that small subpopulation there, and then suddenly you stop the therapy, and those guys can take over, and now that therapy is no longer any good. So there are two schools of thought in HIV, for example, which is hit them hard, hit them first. And there's the same school of thought in cystic fibrosis. Hit them hard, hit them first, kill them all, keep them down, versus lower levels of stuff potentially keeping them down, but maybe leading to resistance.
Yeah, absolutely. Well put, Dr. Byrne. So yeah, to answer your question more, I think the data supports the 4 weeks, but there's no evidence to say you could or could not
What
do.
about the data for the length of an IV treatment? Is it 10, 14, 20?
That's a good question. So yeah, it's a clinician decision, but in terms of
But based on what?
most, I think they would make their own independent choices. I'm not sure when they would. Let me backtrack. I think in terms of published support, usually it's 10 to 14 days in terms of what supports length of therapy. Now, based on patient response, you may lengthen that period. If a patient doesn't look as good as you'd hope at that 10, 14-day window, they may opt to extend it a little further. Again, that'd be a better question to ask an MD, but that's kind of my 2 cents about it.
Can I throw in another thought? Did you pick it up when I'm talking over here? You guys? Yeah? Okay. So one of the problems with cystic fibrosis, which is different from other infectious diseases, is that we don't know when the end point is. The patient does not get cured. There is no better. And so if we're trying to treat, for example, a patient with septicemia and there's organisms in the blood, we check the blood, and when there's no more organisms in the blood, we figure the patient's better, and we take the antibiotics away, and the organisms don't come back, and we've treated the patient. But in a cystic patient, when we take the antibiotics away, the organisms do come back. We never get rid of them totally. And so what is your end point here? And if you just use, what is it, FEV as an endpoint, well, it's different for different people. And other things contribute to that besides just the organism. And so this is one of the major problems with cystic fibrosis treatment is there's no clear end. So all these clinical studies have to use surrogate endpoints, like oxygen tension. And maybe they're real, maybe they're not.
So, to finalize this thought on inhaled antibiotic therapies, there is actually a new one that just came out in the last year, something called Caistin, or inhaled astrienam. We have not used that at Stanford, to my knowledge. I think it's just a matter of getting familiar with the procurement as or getting the drug available for hospital use. So I imagine that will be available down the road. In terms of what are problems with inhaled therapies, as I mentioned before, they really aren't absorbed to the extent that we would expect with intravenous therapy. So there aren't those same hangups that we talked about earlier, particularly the renal toxicity and such. But the biggest issue with them is the chance of bronchospasms. Basically, given the course of treatment, can be a little problematic at times. Okay, so another treatment modality used in the inpatient side is the use of mucolytics. So cystic fibrosis patients often have very thick and viscous mucus. So there are some treatments to help minimize that. Really, 3 that we use are listed here: acetylcysteine, hypertonic saline, and Dornase alpha. Acetylcysteine is that very nasty smelling stuff. If any of you have ever seen that, it kind of has that rotten egg smell to it. This is kind of, I wouldn't say fallen out of favor, but not used a whole lot as much as it was in the past. I think more of that is just based on there's newer treatments that are a little more favorable. One of them being hypertonic saline, was essentially very concentrated salt water. And the gold standard today is really pulmozyme, Dornase alpha. This is targeted for DNA in the mucus to help break it up, make it a little more easier to clear out. So this is pretty much the gold standard that we use today. Okay, so just to finish off, a couple of what I consider some hot topics or questions we get asked a lot in the CF world from the pharmacy end. The concept of what's called ABPA, or allergic bronchopulmonary aspergillosis, and what do we use to treat that? So the name may sound a little confusing. It sounds like you actually have an infection, so to speak, but it's not really the case. I mean, it is a fungus that's colonized in this case in the lungs, but in terms of the way it exhibits, it's more like an allergic response. Patients come in with almost like a hypersensitivity reaction. So the way we check for it as terms of diagnosis, I think they do mainly skin tests, and they look at what's called IgE levels. Basically, IgE kind of tells you if you're having an immune response to something. That kind of helps determine, in this case, if it's ABPA. Treatment for ABPA, like I mentioned, it's not, again, really an infection per se. It's more of a hypersensitivity situation. So with that in mind, the main treatment is really steroids for those acute phases. Glucocorticoids or prednisone for the like are commonly used to control ABPA, because it's not something you can really get rid of, kind of like the Pseudomonas concept. There's, like we do with the inhaled therapies, you can use itraconazole, a fungal agent, to help suppress ABPA expressing as an outpatient. Okay, so another concept that has really got a lot of attention lately is the way we use certain antibiotics. So going back to our beta-lactams graphic here, if you recall the drug concentration and the time going here, and then that being the MIC. So this is kind of the first one I showed. This is how we give a drug. And this is what it looks like. So what we were shooting for is time above MIC to be 50% or more. Now this becomes really challenging in certain patient populations, particularly cystic fibrosis, because you're dealing with very resistant bugs, which can have higher MICs than what we're typically used to, and the capacity that they clear drugs very quickly too. So the goal of getting that time above MIC to where we want it to be can be quite challenging at times. So a concept that they're doing more and more of is what's called extended infusions. So essentially what that means is normally when we give a beta-lactam, the likes of a penicillin type or cephalosporin, they give them pretty quickly, 30, 60 minutes tops. Extended infusions are given the drug over a more prolonged period, 4 hours in this case. And what that does, it lengthens that time above the MIC, and does have some data to support that it does reach those goals that we talked about, that 50% potentially better than giving it intermittently. Now, this does have some hang-ups with it, because you are now, in theory, attached to an IV pole for that period of time. So that, and also limiting nursing availability in terms of use online for other purposes. So it does have some negatives to it, but that is a concept that is gaining more and more popularity, and even in some institutions they're doing continuous infusion. That drug just runs continuously throughout the whole 24 hours. So something else that we've seen more and more of lately, particularly at our institution, is drug shortages. And it's hard to imagine that you would actually run short on drugs in today's world, but that's actually something that we're seeing more and more of, and not really sure why, but there's two main reasons. I think there's been a shortage of raw materials, and that a lot of the raw materials come from outside the U.S., and procuring those materials for the drug companies has been an issue in certain situations. But more importantly, I think it is because the drug companies and institutions are seeing a lot more regulatory issues, a lot more oversight in terms of their practices. And they're having to, in like all institutions, make sure you're doing everything correctly and by procedure and stuff. So that has unfortunately had some negative impact in terms of getting drugs. So there's been numerous cases where drugs literally just are not available. And I'll tell you, there's no worse place to be as a pharmacist than having to tell someone that you literally do not have the drug. There's just nothing you can do about it. Because normally you could just look up the answer later, but no, not in that case.
Could you say something?
Yeah.
So I actually don't have any idea what raw materials would be like. So are these drugs grown, or are they synthesized?
Synthesized, right. Exactly. So the whole, each drug will have its own process, but yeah, exactly. Synthesis in these fancy labs that require a lot of materials, and of course those vary based on the drug you're making, but those materials, depending on what they are and where they come from, mostly come outside the U.S., so not much that's actually within the U.S. In terms of the drug itself, yeah, it's a synthesized process. A lot of drugs do have natural origins, but in terms of today's practice, they're all kind of lab-created, so to speak. Okay, so I saved what I consider the most important thing for last. What this graph illustrates is what I see as a very concerning topic in the field, and that is the dwindling pipeline of anti-infectives. So as you can see, this kind of the timeline here, broken down by periods of years, and the number of antibiotics that came out. And you can see from the 80s until where we are now, this is going downwards, and that is not a good way to go. And the reason for this is not really sure, but I mean, if you were a drug company, if you were to think of anti-infectives, it's probably not the best bang for your buck versus other treatment modalities, cardiovascular, cancer therapies, et cetera. So unfortunately, as of, excuse me, last I heard, there's only about 15 or 16 drugs that are in study in anticipation of hopefully getting approval. Of those, I think only 8 of them are targeted to, or the really problematic bugs, the gram-negatives, the Pseudomonas types. And unfortunately, none of those are unique in terms of their mechanism of action. And so all those resistance that we're seeing now are very susceptible. All these drugs in development are very susceptible to all those resistant patterns that exist today. So unfortunately, as we stand right now, it seems like there's little hope. But that being said, power much higher than I've ever met. But at the last IDSA conference, Infectious Disease Society of America, they initiated a campaign called Bad Bugs Need Drugs. So essentially, it's a concerted effort by a lot of regulatory and accredited standards to gain more awareness within our government to, I don't want to say pressure, but hopefully open the eyes of the drug companies to increase their capacity to research anti-infective therapy a little better. So their slogan, aside from Bad Bugs Need Drugs, is 10 by 20. The hope is by the year 2020, we'll have 10 new antibiotics, and new meaning new mechanisms, new novel therapies that can offer some hope versus kind of the retreading that we're doing with the ones that are currently coming out on the market. And with that, I think I'll stop there and answer any questions.
When you use the continuous infusion, do you have to use is it over a 24-hour period, is it a higher level of medication than it would be if you were only giving it in 1 dose or 3 doses?
So yeah, so let me go back to that. I did not unfortunately map out the continuous infusion, but from the extended infusion, well, I can answer one of 2 ways. So the continuous infusion will kind of hang a drug level, I didn't, again, draw it out, but something like this. For the whole 24 hours, it runs continuously. Extended infusions, like I said, normally we give a drug 30 to 60 minutes. Extended infusions, for the most part, usually hang for about 3-4 hours at a time, and then they're taken off. So for more common drugs, for example, meropenem, which hangs 3 times a day, it would hang literally on the pole for up to 12 hours and then be off for 12 hours. And again, you're just kind of keeping that goal of that time of MIC, shooting for that. They don't necessarily get higher peaks. If anything, probably get a lower peak. But that, again, that's not really important to the way the drug works. It's really how long it can stay above this level.
So if you were going to give 1 gram every 24 hours, would you still give 1 gram over 24 hours?
With the continuous infusion, that's how it would work. You just, pharmacy would make a bag in the sense of 1 gram a bag, and that would hang for the 24 hours. In these extended infusion cases, it's kind of split into multiple doses throughout the day. For example, in that case, maybe 500 milligrams twice a day or 250 milligrams, and those are given 3-4 times a day.
Can you comment on absorption of itraconazole? Some people favor oral pills, some people favor liquid for CF absorption.
So yeah, there is actually, it's the same drug, but there is a difference between the PO and the liquid form. And essentially it is not the drug itself, it's the way it is absorbed in your stomach. PO tablets, or sorry, the capsules are not absorbed well in non-acidic states. What that means is often patients are on acid suppressors, the likes of Protonix or Prevacid or famotidine, those types. Those limit the capacity of the capsule forms to absorb well. They really need an acidic environment to better absorb. So in those instances where the thought is best to keep them on an acid suppressor, that's when the rationale of using the oral solution, because that drug is it can be absorbed in those non-acidic states. So from the inpatient perspective in the hospital, most of our patients are on acid suppressors. You can almost expect that they'll use the solution form.
On some of these continuous or extended or continuous or starting from high levels where they extend out a period of time, we've talked about the side effects, the negative side effects particularly. Those, at least by the graph, saying longer times at high dosage, aren't you exacerbating the potential side effects? or is it cumulative anyhow, however?
This is a great question. With the case of beta-lactams, the side effects really aren't dose-dependent. What that means is it's not really tied to how much of a drug or how high this level gets, unlike other drug classes. For example, the aminoglycosides or glycins, that would be very relevant, how much drug you're given at one given point in time or how long you have it running, so to speak. The beta-lactams, in terms of how long it's exposed to the body, really not so much of an issue in terms of its adverse effects. Those will probably exhibit one way or another. It's really not dose-dependent.
So some of these kind of therapies would be good for certain classes, but not
Right,
for
yeah,
others.
exactly. Sorry, this particularly is used for the beta-lactams, so those are your penicillins, the cephalosporins,
But
those
not for
types.
focal
Yeah,
penicillin.
exactly,
Good.
right, yeah. So with the aminoglycosides, what they've done is that once daily concept, given a lot more upfront, getting a high peak, which means the drug works better that way, and then not having to give it again for 24 hours, you let that level drop off to a point where the risk of hurting the kidney, so to speak, it doesn't.
So, I never thought of this until just this discussion, but when, if someone with CF is taking drugs their whole life, does their natural flora become drug resistant?
I wouldn't say it would become drug resistant per se, but their natural flora is affected, absolutely. To what extent and what degree, it'd almost be a case by case. But patients that, I mean, generally speaking, anytime you're exposed to drugs for a period of time, antibiotics for any period of time, the chance of developing resistance increases every single time, every single day you're on the drug. So those that are on lifelong therapies, that's pretty rare that you would have someone that you could use the same antibiotic effectively through various treatment courses. The chance of that resistance developing was pretty great.
Can staph bacteria suppress other bacteria if it's untreated?
I'm not exactly sure if, would it suppress other bacteria? Maybe that's a question Dr. Barron can comment on. I don't believe so. I mean, the lab would tell us if.
No,
they're not
there
seeing
are
it.
some bacteria. The whole reason that we have antibiotics at all originally is that bacteria are growing in colonies in the natural environment, whether it's in you or in the soil, and they're producing substances to kill off the competition so that they can take over the environment. And those are what antibiotics are, bacteria making some killer enzyme to kill off the next guy. So that penicillin, a mold, for example, produces penicillin mold, penicillium is the name of the mold, produces an enzyme that kills bacteria so that it can kill off the competition in the soil. That happens in environments, and it happens in all the ecological niches of the body that certain organisms produce toxins that affect the other organisms. Staph aureus is an organism that is colonizing normally the nares, the lower part of your inside of your nose, occasionally other areas of the body, the axilla, the hairline, the perineum. So that is an organism that colonizes those places. It grows on some of the natural sebum that's in your skin and things like that. But when it gets there, it doesn't actually kill off the organisms nearby. They exist in harmony. Certain other organisms do kill off nearby organisms and take over, but they're mainly pathogens. They're not the normal organisms that we have grown up with over the last millions of years. Those organisms have all learned to peacefully coexist as well as they can and to share nutrients. They grow in colonies because some of them produce a substance like Haemophilus. The Staph aureus produces a substance Haemophilus needs to grow. And so they grow together as a colony because they like it in that mixed community. So I hope that answers your question. If they killed off the other competition, they'd probably be a pathogen and not a normal colonizing organism.
Is there a benefit of chronic antibiotic use as a preventative measure versus as needed treatment only when symptoms positive cultures?
That's a great question. From my understanding, I think in Europe they tend to take that approach where they'll often have patients come in for tune-up, so to speak, where they'll come in for IV antibiotics, not with an acute exacerbation exhibiting. So there is some schools of thought behind that. I think in the U.S. and Stanford specifically, we don't practice that way. Not to say it's wrong by any means, but I think we tend to treat in those acute stages where the patient comes in feeling a little worse for wear.
There was a question about pulmozyme and hypertonic saline. If the pulmozyme, let's see, I heard before that you can not use pulmozyme soon after hypertonic because it denatures the enzyme. Is that true?
Yeah. We would recommend that the times of administration be separated. The exact timing of which, hard to say, but in our practice, we try to at least an hour apart. In the worst case, in our world in Stanford, we have the ability to set schedule times when we see fit. But for patient use at home, I'd recommend probably at least an hour apart.
If the culture just says staph aureus, does that mean it is MSSA?
I don't think that is definitively saying it's MSSA versus MRSA. Usually you have to do a separate test to make that determination, and Dr. Barron could probably shed some light on that.
We would report the Staphylococcus aureus maybe right away, as soon as we identified it, and then we would have to do a separate test to identify whether it was methicillin resistant or susceptible, and depending on what method we use molecular methods in our lab, so we can actually report the resistance within a couple hours of reporting the organism. That's new, and that's not common in hardly any other lab in the United States, but we are able to do that at Stanford. Other labs normally have to do the susceptibility testing with the disc, like I showed the picture, and that takes overnight incubation. The result wouldn't be available till the next day.
Is that an automatic thing for anyone who cultures staph? You would check for resistance?
Yep, every staph we see, every staph goes right into the molecular test, and we run it more than once a day. Once? Once. Okay, never mind, once.
Yeah, I must comment that the capacity to have that quick of a turnaround has certainly impacted patient care in a very positive way. Something the lab actually published, I think, last year or the year before.
We published that. It cut down on the length of stay of patients by half who had Staph aureus in the blood, and it cut down the use of vancomycin by half as well. Because as soon as you know that the patient does not have MRSA, methicillin-resistant Staph aureus, you stop using vancomycin because it's not the best drug. Nafcillin or other cephalosporin would be a better drug for a methicillin-susceptible staph. And so the patient gets better treatment, gets to go home earlier. Vancomycin, which is only IV, gets to be stopped. All kinds of good things happen when you know whether it's MRSA or not.
We test for Medicaid every time, PCR for staph, even if we don't do sensitivities on CF patients.
Right. Okay,
Although
that's good
for
to
up
know.
to 3 months.
Yeah, remember we talked about every 3 months we redo the susceptibilities, but every time we see a staph, Manju reminds me, we run the MRSA test immediately.
And if it's changed from being susceptible to being resistant, we'll do a full sensitivity.
Okay, great.
We make sure it remains MSSA, or we check for MRSA or MSSA every time, even if we don't do a full plan.
I have another microbiology question. So I was fascinated by the 2.5 hours versus 15-minute comparison. And the other thing that makes people with CF different is that we're putting cultures in all the time. Most people maybe get an infection once every 20 years. So the bottom line is, what proportion of the clinic's business, as it were, would be CF? Is it still a tiny proportion, even taking that into consideration, or is it big?
It's big. There's a whole person basically devoted to nothing but cystic fibrosis respiratory, just about.
But it's not like over 50% or something like that,
No.
because, I mean, there's a lot of other infections.
Sure. I was wondering, is it like closer to 5 or closer
Oh,
to...
you're thinking in terms of all of microbiology. I was thinking in terms of the sputums, the respiratory.
Actually,
But-
I am too, actually, just
Oh,
respiratory.
okay, so how much for respiratory? What's the percent that the time would be a lot, but the
Yeah.
numbers of cystic
We get a
patients?
lot of sinuses, so it's hard to tell, respiratory and
Mhm.
sinuses. You can only speak for Stanford, perhaps.
No,
That's
speak
all.
for Stanford.
It's probably about 40, 60, yeah.
Yeah, Stanford has a big cystic fibrosis population, we have both adults and children.
Sure.
And so I think our numbers are much higher than community hospitals. But if you look at the CF Foundation webpage and you see where the study sites are, my guess is that all of the academic centers associated with those study sites would have the same kinds of numbers as we have here.
Plus, we have recurring patients.
They all would,
They
yeah.
keep coming back, so we have those numbers. Whereas sinus infections or some hospitals, people, they come and go. You don't repeat them.
I think that I can speak for the online community and that this is so rich. I'd like to give an opportunity for 2 more questions from that group before closing out this session. So
Yeah,
Ed?
sure.
Yeah, I have a question here about oral antibiotics in treating Pseudomonas. What do you think about that?
The use of oral therapies, yeah, it's certainly an option. I think the question would be, what is the clinical scenario of the patient? Someone with, as we say, an acute exacerbation, declining PFTs. I think the more reliable method would be to start with IV therapies, and when you get an improvement in that clinical status, then maybe make that transition to oral therapy. If it's used in other capacities, a controlling type agent, then there are some options for that too, but we don't practice that way so much in Stanford. I think they tend to reserve treatments for those acute settings, and then it would be IV until they're a little more stable.
Okay. And about staph again, whether it should be treated with antibiotics, and if so, which one?
That's I'm not sure exactly to what extent that question is aimed at, but staph in general for the CF population, it's often colonizing patients, so it's there. I guess the question is if the patient is in a state where they need treatment, an acute exacerbation, as we say, declining PFTs, yeah, I think that would be a scenario where you would initiate therapy. The question may be what therapy to go with. I think it really depends a lot on what type of staph you're dealing with. For example, MSSA versus MRSA. If it is MRSA, what is the MIC of the agent, of the bug, because that often dictates therapy. Generally speaking, as Dr. Barron commented on, MSSA, you tend to use drugs like nafcillin or maybe a cephalosporin. MRSA is really vancomycin or linezolid that are used first choice. But despite all that, I think sensitivities would dictate which way to go down the road based on that individual patient's results.
Well, excuse me. Tonight we've been so fortunate to have Dr. Ellen Jo Barron and Deepak
It's tough.
Sisodia.
There you go.
Sisodia, joining us for our CF Discovery Series. I want to thank these 2 experts who are well known in global communities for coming to us tonight. Aren't we fortunate? I want to thank all of you for coming tonight, too, from your busy lives, and thanks to our online community for joining us. We've had many followers of this discussion, and I think that just points to the niche that we fill at CFRI. I am not an expert. We're a staff of 4 good people. We are not the experts, but we bring the resources to the community so that we can have that sharing of information, because the more informed we are, the more we can choose the best options, the best quality of life. Thank you all very much. Stay tuned for us coming around the corner March 8th for our next CF Discovery Series. Have a good evening. Oh, you're welcome. Thank you for your patience. We're sitting here.